analysis, space analysis, to determine which teeth should be moved, and we project their final positions for optimal dental-facial relationships. We want to control movement as per the treatment plan. So for an example, we have an individual with crowded teeth and also a degree of protrusion. We want to take out bicuspids to assist that alignment. We don't want the posterior teeth moving forward into that extraction area. We want the front teeth to uncrowd and move backward posteriorly to assist in the protrusion reduction, for example. In clinical practice, anchorage units tend to move, and in fact, it's more difficult to maintain tooth positions than to actually move them. We have anchorage intraorally, anchorage within the mouth. We have extraoral anchorage, anchorage outside of the mouth. An example of extraoral anchorage would be headgears, cervical headgear, and the slide on the right, horizontal pull in the middle slide, high pull, slide on the left. This is what headgear looks like. It's inserted into bands that have round tubes welded on them. Headgear isn't used today as much as it was in the past. I can tell you that if you have a very young person, mixed dentition, they'll respond to this better. They'll wear these kind of devices. You can forget about it in the middle school crowd. So you need somebody very disciplined, and it's a beautiful appliance, but the problem is you need compliance. Another example of extraoral anchorage using the forehead and the chin. In this case, face masks used in a class 3 malocclusion in which you want to protract the maxilla. We have intraoral anchorage now. We can have anchorage within one arch. In these slides, we have a spring on the upper portion, a chain or elastic on the lower portion, and we're pitting on each side 3 posterior teeth against 2 anterior teeth on the left. Anchorage between arches, intraoral anchorage, elastics used all the time in orthodontics, anchorage between the maxillary and mandibular arches. We can talk about anchorage types: simple, stationary, and reciprocal. In simple anchorage, the anchored tooth is allowed to tip. In stationary anchorage, the anchored tooth, we're setting it up in such a way that it can only move bodily or translate. This is a slower, more difficult kind of movement. Or reciprocal anchorage. Say we have an upper diastema between the centrals, we put on some brackets, put an elastic on the brackets, and the teeth will move together. Now we're opening space distal to the centrals, but we're doing this most always with some kind of cosmetic bonding procedure, done all the time in clinical practice. Simple anchorage here. We have 2 teeth, an extraction space, and an elastic. The tooth with 1 root on the right will tip more, as you would expect, than the molar on the left. Stationary anchorage, we're utilizing 3 teeth on the left versus 1. On the right portion of the slide, 2 posterior teeth versus 1. So we're setting up anchorage so the posterior segment is only allowed to move bodily, which is a slower type movement. And reciprocal anchorage, another example of that is a crossbite in which you have bands cemented on the teeth. Patient wears and elastic. There's no wires here, and it can lead to some very nice crossbite correction if, again, you have compliance. We can look at intraoral anchorage at the level of teeth, the basal bone and overlying soft tissue, and the cortical bone plates. Intraoral anchorage, looking at teeth. We look at root form, we look at root size and number, root length. Quite simply, we can break this down into root surface area. The more root surface area present, the more strong the anchorage unit. Comparing, for example, a upper first molar versus much less anchorage with a lower incisor. Basal bone and soft tissue anchorage, we can use the hard palate and the lingual surface of the mandible as anchorage. So here's our example of what I was referring to earlier. We have crowding. I set up a scenario with the treatment plan that there was also protrusion present, and we extract first bicuspids, but we're not only relying on that, we're putting in this Nance holding arch to hold posterior teeth back and promote anterior alignment and reduction of the protrusion. With regard to cortical bone plates, the cortical bone plates are dense, laminated avascular areas, and these areas resist tooth movement. Cancellous bone promotes tooth movement. So that if we have an appliance, an orthodontic appliance with a wire, and we can move the roots close to the dense cortical bone, this will resist anchorage, will resist movement, and enhance anchorage. The ultimate anchor, a TAD, used to assist anchorage. In the following situations. And in the last slide, we're using a TAD to upright a molar to allow for a better path of insertion for the prosthetic replacement.